And it's great to see how many people are here today. As you know, it's a very exciting time for people with bleeding disorders. And I think as I was sort of thinking about this, it's very exciting right now. I think the next 5 to 10 years will be even more exciting. I think sometimes it's helpful to kind of look back and see where we came from to get a better understanding of where we're going. So there was four, I'll speak very briefly. There are 4 areas I was going to touch upon. I wanted to, as I was thinking about this, I had some reflections of my experience in medical school. I wanted to talk about the evolution of treatment strategies, specifically for hemophilia. I wanted to touch on some treatment strategies for individuals with rare bleeding disorders, and then finally talk about some non-factor therapeutic options. So interestingly, in medical school, I had 4 separate experiences that really struck me at the time that had to do with hemophilia. And interestingly, medical school was 4 years long, and it was each of these experiences in each of the 4 years. In my very first year, I was in a pathophys class, and to introduce us to hemophilia, they brought in a panel of patients and families. There were 3 boys ranging in age from 6 to 16, and their parents came to describe their experiences. And basically, what we heard from them is they had significantly limited their physical activity. They were encouraged to engage in low activity sports, swimming, that sort of thing. One of the boys was very proud of the fact that he could tell the early signs of a hemarthrosis, so he could alert his parents to seek medical care, and he actually was in the process of learning how to self-infuse. So that was an interesting experience, particularly as we sit here today and look back on that. The second experience was in my second year of medical school. I was on a neonatology rotation, and a newborn boy had just had a circumcision, and it didn't stop bleeding. The urologist came, they put sutures in, they bandaged him up, and he kept bleeding through all the bandages and sutures. Kept bleeding and bleeding. So we sent off a PTT. It was over 100. It should be around 30. Sent a factor 8 level. It was undetectable. So we made the diagnosis of severe hemophilia A, and we had a meeting with the family. And during that meeting, the hematologist who was there talked about the fact that they were going to have to be very careful with their boy. They're going to have to limit his activity. The good news is we do have purified factor that we can infuse when there's injuries and that sort of thing. So that was the message to this family. My third experience is in my 3rd year of medical school. I went to my very first hemophilia comprehensive clinic. And as most clinics work, you sit down before the clinic and have a pre-clinic conference, and everybody introduces themselves. And the last person to introduce themselves was an orthopedic surgeon. And I wasn't really 100% sure why they were there, but it was very clear once we went to clinic, it wasn't a matter of if these boys had target joints or not. It was like, how many target joints do they have? And the orthopedic surgeon would meet with them. There's various strategies to deal with chronic arthropathy, including joint replacement. And in my 4th experience, I was about to graduate from medical school, and I did an infectious disease rotation, and we had a journal club, and the article was from the Mortality Weekly Report, and it reported 2 patients with hemophilia who had died from pneumocystis pneumonia. And at that time, pneumocystis was felt to be a very rare, only present in people with immunodeficiency. So that seemed pretty strange, and nobody really understood exactly what was going on. I think everybody in the room now, looking back, knows exactly what was going on. So when I left medical school, these were my takeaway lessons in terms of hemophilia. Patients with hemophilia should be bubble wrapped and minimize their physical activity. Treatment is reactive, on-demand factor replacement, after the onset of a bleed. Orthopedic surgery and joint replacements are key parts of hemophilia care. And finally, there was this observation that hemophilia patients were developing unusual infections only seen in immunocompromised patients. And even after that experience in medical school, I decided to go into hematology. As we look back on where we've been, early treatments for hemophilia, magic spells, ice, bed rest, splinting, snake venom, a lot of these we still use, magic spells, ice, and bed rest for sure. In the 30s and 40s, it was recognized that patients with hemophilia, the clinical phenotype had been identified, the inheritance had been identified as X-linked, but it was really in the 30s and 40s that we realized that there was a factor in the blood that was missing. So what do you do in situations like this? Give people blood. So in the 40s, we were giving people whole blood transfusions, which included factor VIII, which included factor IX, included everything, all the causes of rare bleeding disorders. But people didn't really need all that. They certainly didn't need the red cells, white cells. In some cases, maybe the platelets would be helpful for some of our other rare bleeding disorders, but they didn't need all that. So people said, okay, that makes sense. Let's give them fresh frozen plasma. So as we evolved into the 50s, fresh frozen plasma was developed, and that was the mainstay. Another interesting time point in the 1950s was 1957. The New England Hemophilia Association was founded. I didn't realize that, but it's been around for a long time. Then through some work in Toronto, it was recognized if you take plasma and freeze it in a certain way and warm it, you can concentrate the plasma to contain high levels of fibrinogen and factor VIII. So cryoprecipitate was used in the 70s. Lyophilized concentrates of factor VIII and factor IX were developed, and this was from plasma, multiple donors of plasma. In 1973, the Hemophilia Act federally funded comprehensive hemophilia centers. In the 80s, both factors VIII and factors IX, the genes were cloned. And I think, as everybody in this room knows, in the 80s was also a time where HIV and hepatitis epidemics hit the community. And this was followed by a reaction of doing viral inactivation of plasma products and HIV screening. And another NEHA milestone in 1992, Family Camp, which many of you have attended, started. That was quite a while ago. In the 90s, recombinant factors, VIII and IX, were developed. The whole concept of, rather than on-demand reactive therapy, maybe we should prophylax patients, that came about in the 90s, so prophylaxis strategy was developed. Also in the 90s, von Willebrand factor concentrate was approved. As we get into the 2000s, plasma-derived fibrinogen concentrates for patients with afibrinogenemia were developed. The strategies in the 2010s included extended half-life factor products, and those strategies are continuing to this day. Recombinant factor VII was developed, and we also developed plasma-derived factor 10 and factor 13 were approved. Just over 5 years ago, emicizumab, a bispecific monoclonal antibody bringing together factors 9 and 10, which is basically the function of factor VIII, was developed and pretty much revolutionized therapy for patients with severe hemophilia A. In the 2020s, currently we have gene therapy has been approved for both hemophilia A and hemophilia B. And more recently, there's been some development of looking at the tissue factor pathway as a common pathway to inhibit, to promote clotting. And this would be, if it turns out to be successful, would be applicable to hemophilia A, hemophilia B, and probably pretty much any bleeding disorder. In terms of treatment considerations, the most common bleeding disorder, as most folks know, is von Willebrand's disease, affecting about 1% of the population. Males equal females. And a lot of these patients have mild disease. I know many of you attended Dr. Rosenfield's presentation at noon, von Willebrand's disease, and that was wonderful. But a lot of these therapies include local therapies, DDAVP, Amicar, tranexamic acid, hormonal therapies, and also available to us are von Willebrand's factor replacement. Hemophilia A, which affects 1 in 5,000 males. Again, we can divide things into sort of mild versus severe. Some of the same strategies we use for von Willebrand's for our mild patients, and then we have for our severe patients factor replacement, emicizumab, gene therapy, in a similar way for hemophilia B, which is much less common. Just a few notes on rare bleeding disorders. This is the list here, and as you can see, the various factors that are affected. In general, these are rare, and in general, these are in the one in a million in terms of incidence. And for all of these, FFP will work. For some, factor concentrates have been developed specifically for fibrinogen, also for factor 7, factor 10, factor 13, and in Europe has factor concentrate for factor 11. The mainstay of therapy for hemophilia A and B has always been factor replacement, but it's important to keep in mind non-factor therapies, obviously local control, rice, which we recommend to all of our patients, glue, other mechanical strategies, hormonal therapies for heavy menstrual bleeding, and Katerina will be talking a little bit more about this to follow. Antifibrinolytics for mild hemophilia A or von Willebrand's disease. With DDAVP and stimulate, which will increase levels of post-factor VIII and von Willebrand's disease. I mentioned bispecific monoclonal antibodies, that's emicizumab, gene therapies, and then the tissue factor pathway inhibitors. So those are some of our newer therapies. And from all of us at the Maine Bleeding Disorders Center, we'd just like to say thank you for inviting us today, and thank you for being part of your community.
Thank you very much, Eric. Eric Larsen from the Maine Bleeding Disorders Center. Thank you. And now we have Katerina Funk, who's going to take us into the next section, talking a little bit more about women in bleeding disorders. So, Katerina, over to you.
Okay. Thank you for inviting us. I know I've attended the breakout session this morning before lunch, and I've attended the women's group, and we specifically talked about the challenges of mothers and women living with bleeding disorders. So this was a nice sort of insight for me going into this presentation. Historically, risk of bleeding for women who had bleeding disorders was perceived as minimal or non-existent. However, they continued to suffer from multiple bleeding symptoms, including bruising, bleeding, postpartum hemorrhages, post-surgical bleeding, and so forth. Bleeding disorders also presented serious added consequences for women and girls due to gynecological challenges. So it's heavy menstrual bleeding that women had to suffer for a very long time, for years, and also the challenge of childbirth. And what is even more challenging is that even though the carrier status was known, the correlation between being a carrier or having a mild disease and also being a patient was not established. So I did a little math exercise. I don't know if any of you know, but American Thrombosis and Hemostasis Network, ATHEN, so that's probably a lot of you patients participate in that research. Sponsored by the CDC. It's data that's reported to allow for better data collection and really establishing better therapies. So I did a little exercise. So from 2012 to 2022, Community Council, that's one of the branches of the ATHEN, there were a report of total 22,476 patients with hemophilia A. So that's the total number of all patients, male and female. And then out of that number, 19,499 were males, and 2,977 were females. However, we do know that for every male, there is at least one female on most times outside of the spontaneous mutation who also at least a carrier of hemophilia A. So that number should not be that disproportionate. So what we do know is that approximately 2.725 women for every male who has hemophilia are probably affected by this diagnosis. The other problem is the levels, right? That's the topic that we talked this morning about, is that, what is mild? What does it mean to be a carrier? That even levels of 50 to 60%, which is technically above the diagnosis threshold. The normal level for factor 8 and 9 is going to be 50 to 150. So that's technically a normal levels, but they have been shown to be associated with increased risk of bleeding, and that's a variety of bleeding symptoms that can be presented. What we see, so I'm a family-trained nurse practitioner, so I see a lifespan, so I see girls and I see women, and a lot of times having menstrual bleeding is the reason for referral to our clinic. So what is important to understand that, probably 30% of women do suffer from heavy menstrual bleeding, all women. Out of that percentage, 10 to 30% may have an underlying bleeding disorder. So it's really important to, it's a large number of women that can be affected. So it's important to identify them and treat them appropriately. And so a lot of times, having menstrual bleeding is the first symptom of a bleeding disorder for girls. So this, just a little schematic as to, how do we, I was going to show that for every male with hemophilia, there would be potentially daughters affected. His mother can be affected, his sister could be affected. So it's important to talk during comprehensive clinics about women in life of men. So that's the practice that we have started to practice in our clinics, is that when males come in for their comprehensive visits, we talk about women in their life. And a lot of times they do not know. Men do not typically talk to their daughters about their periods, but when this sort of light and education provided, it's important, and we now start to get phone calls from other relatives of our patients. So this is the von Willebrand's, the same. So it's a very, as Dr. Larsen mentioned, von Willebrand's disease is the most common bleeding disorder. It's 1 in 100 birth. 1% of population has it. It affects equally males and females. We do see women more often because of the periods. So having menstrual bleeding, usually the first symptom of underlying bleeding disorder in women. A lot of times, even though it may be the primary diagnosis for, or primary reason for referral to a hematology clinic, we a lot of times either refer or also ask primary care providers to refer these women and girls to an obstetrician and gynecologist, because it is important to rule out other reasons for heavy bleeding. So a lot of times what we do recommend is collaborative care for these women. And the reason for that, because the management strategies for heavy menses are usually combined. So the first step is likely going to be hormonal contraceptives. It could be a pill, it could be a patch. And then we usually kind of go on an escalation of this therapy. We do combination of combined oral contraceptive or patch with tranexamic acid. We can use the intrauterine device and tranexamic acid. And then from there, if it is DDAVP that can be used, so it may be von Willebrand's disease, it may be mild hemophilia A, we do use desmopressin, DDAVP. We do use factor. And then we collaborate with our gynecology colleagues about more invasive measures, which is uterine ablation or hysterectomy. As I said, this is more of escalation of therapy, so we usually try to stay in this area. Or maybe intrauterine devices are probably the most effective way of management of periods. The next step I wanted to cover was preconceptive planning. The reason it's extremely important to know whether or not a woman is carrying one of the bleeding disorders. A lot of times what we see is there's lack of knowledge. It could be truly lack of knowledge, it was never mentioned, or it may be just heavy periods running in the family. It was never isolated as a potential issue. Sometimes we see as a fear of knowing diagnosis. But however, what it does, it really allows better planning and seeking professional help at the right level of care. And this is crucial. A lot of times we do recommend women who have bleeding disorders to be delivering their children in the centers where there's factor support available, where there's blood product support available, where there's NICU team and a high-level obstetrics team. And a lot of rural hospitals are not able to support that. So knowing about these problems early in pregnancy or even before pregnancy happen really allows women to have a safe prenatal course, delivery, and postnatal care. Again, we collaborate at Maine Medical Center. We work together with a lot of local obstetricians. We do work very closely with maternal and fetal medicine at Maine Medical Center. What is important to know? So for hemophilia A and von Willebrand's disease, factor levels elevate, typically in pregnancy, so a lot of times women are able to deliver fairly safely without additional interventions because those factors are acute phase reactants and they elevate in pregnancy. However, with hemophilia B, certain von Willebrand's disease, our other rare bleeding disorders, we need to be involved from the early stages on, and we plan significant interventions at the time of delivery. It may mean additional factor infusions. We do work in collaboration with anesthesia. There are certain bleeding disorders in which epidural anesthesia is not an option. That's a lot of qualitative platelet defects because they're not measurable levels, because it's quality of platelets, not the number of them. So a lot of those things are important to know sometimes, better before getting pregnant or at the early stages of pregnancy. Sex of the child is important. Does the family plan for circumcision? If it's a boy and the circumcision is desired, we do recommend cord blood testing at the time of birth to establish safe procedure. If the levels are low, we typically recommend avoiding and waiting until the child is older. I did mention pain management, complications. Again, postpartum hemorrhage, even though the levels may be normal at the time of birth, they can drop precipitously within 7 to 10 days post-delivery. So we are involved in the postpartum stages of care. So our center is usually following up with these women. We do educate that the normally kind of higher level of bleeding as women expect can be much more severe in women with bleeding disorders, and we want to know about that. That's what I prepared for the presentation today. Thank you.
All right, thank you very much. We appreciate that. Let's make a little noise, warm those hands up for Katerina Funk and Eric Larsen. Thank you. A little friction on the hands there. Keep those warm. All right, so here's what we're gonna do next is I've got this slide that's up behind me, and you can scan the QR code like you're going to your favorite restaurant, and you can write me secret messages that are going to come into my computer. I am the only one who's going to see them, unless they're good, and then I'll post them. Just kidding. But what's going to happen is you can type in a question, and what I'll do is I'm going to act, like I said earlier, I'm going to distill your questions, and we're going to ask the two panelists up here, and they're going to help us out. Another way to think of this session, I was reflecting as you guys were speaking, is these two wonderful panelists just built us the framework of a house. And they just built the walls, and they gave us some really good background information, and they kind of gave us what we need to know to build a foundation. Now it's up to you, the room, to submit your questions, which will be the decorations, to bring this house to life and to really help bring some flavor and show us what we've got. So, this is your chance to shine. We have about 25 minutes left. And if you guys don't ask questions, I've got a few that I've got cooking up that I was scribbling furiously on my the notes section of my beautiful program. Whoever made that must be a really good-looking guy. So I'm hoping that all of you can help us to contribute and put this together, and we'll ask some good questions to our panelists. So scan that QR code. I'm going to see if I can figure this out without losing the QR code. I'm going to see if I can switch over to start seeing those questions come in. Here's to hoping. Ooh, the good stuff's already coming in. All right, so I'm going to start off with Dr. Larsen. This one's for you. Ready?
I'm ready.
All right, fast and furious. The first is, Dr. Larsen, please comment more on non-factor approach to control bleeding, such as TFPI or AT inhibitor.
Great. Can you hear me?
Yeah. Sounds good.
So tissue factor pathway is a common pathway starting factor 10, 7, and then going down to factor 2, and then fibrinogen, and then the fibrin clot. So like anything else, blood is this magic substance that's liquid, but it can instantly become solid in terms of forming a clot, but then you also want to be able to break that down. So there's a lot of forces that are causing you to bleed. There's a lot of forces that are forcing you toward clot. So there's this balance, and there is a number of molecules that the tissue factor pathway inhibitors. So they're inhibiting that pathway. So the whole strategy that's been developed is to inhibit the inhibitor such that a clot will be formed. And these are, I think there's 3 various monoclonal antibodies that attack the inhibitor in different places that will allow for clotting to form, because the inhibitor is trying to, the result of that would be more bleeding. And I think a number of these antibodies are currently in trial. I don't believe any of them are approved, but the hope is that they will be FDA approved at some point. And the beauty is they should work for pretty much any bleeding disorder, certainly for hemophilia A or hemophilia B, but most likely they would be helpful in pretty much any bleeding disorder.
Excellent. I hope that answers whoever's question that was. Also, just putting it out there, I'm going to just say this. I think afterward, if folks have additional questions or would like to follow up on something, I think you guys might be around, excellent, to be able to do some follow-up. One of the beauties of this situation, by the way, is that folks can ask questions that they might not want to ask out loud. Also, it's an efficiency thing, helps me roll a little bit faster. But if you have a follow-up, you're welcome to come up and ask these 2 excellent panelists who can give you more. We're going to go over to ask some questions about women. The first is going to be, Katerina, how do you deal with parents who don't want their adolescent daughter on hormonal control?
Sorry.
That's a very challenging situation.
Yep.
Certainly there's a lot of cultural reasons. We're all entitled to our opinions. We do value patients' autonomy. So we work with what we got. So we do try to explain the fact that hormones. We use hormones not for birth control. We use hormones to regulate heaviness of bleeding, and I think this is the best sort of in its factual. IUDs are great, but they're more invasive. If none of the hormonal options are working for our patients, we do use tranexamic acid, which is an antifibrinolytic medication, and see if that as a monotherapy works for our patients.
Excellent. Thank you. Staying with you, I have an additional question.
Okay.
when is the most appropriate, when is it most appropriate for young women to see a genetics counselor when they start the question continues, when they start dating, marriage, when they get pregnant? Some thoughts on that?
I would say at the time of diagnosis. Our HTC has embedded genetics counselor, so that person is a part of every comprehensive clinic in our center. So we do recommend having, I guess this is one of really the recommendations, and one of the guidelines is for women to get genetic testing whenever able, especially in the setting of potential hemophilia A and B diagnosis. We do have and schedule additional sessions with genetics counselor when there's a conversation about conception. But the best would be your kind of initial talk should be at the time of diagnosis, so because that really guides and helps to plan your life moving on.
Awesome. I just realized that there's more questions as I scroll down, so surprise to me. A couple of, there's a good one that just came in, the last one that just came in, and I'm kind of interested in this. This one can be for either of you, but perhaps Dr. Larsen, is rice still the standard, or has that been proven outdated in lieu of meat? Which stands for, and one of these words I actually don't know how to pronounce, so I'll just butcher it because it's meat. Meat standing for movement, exercise,
analgesia?
That one, and treatment. I've never seen that word before.
Whoever submitted that, I kind of miss the fact that we don't know who's asking these questions, but
Yeah.
That was a great question. I tend to like to mix my rice and my meat together.
I love it.
Quite seriously. I think we can use all of those strategies. I think the point there is one thing that's very challenging for us is, and I think all centers get this, you get the phone call from home and somebody's knee is sore and it's not really swollen. It's not a clear-cut, full-blown hemarthrosis. But could it be a microbleed? You're really not sure. My training in medical school is, to treat first and ask questions later, but I do think that we're probably, that strategy probably leads to a lot of patients being overtreated. So there's clearly, I think, a role for both rice and meat, and in selected patients, factor replacement.
Excellent. I have a slew of food jokes, but we just ate, so I'm just going to let them all sit, but thank you for that. Glorious buffet of an answer. And there's a follow-up question that actually kind of nicely flows into what you just were talking about, which is when you're in medical school. Somebody asked, what would your insights on hemophilia or bleeding disorders be today compared to when you were in medical school?
That's an excellent question. First of all, would anyone hazard a guess about when I went to medical school? Separate from my physical appearance or disappearance? 80s.
Yeah, everyone's nervous right now.
It was 80, I graduated in 84.
Excellent.
So you're absolutely right. But no, I think, it was interesting to be asked to be part of this panel because I did kind of reflect on a number of things, not only medical school, but those experiences I found pretty discouraging, and there was certainly hope, and people were talking about making factor concentrates and that sort of thing. But I found all the experiences I shared with you were pretty discouraging.
Yeah. Continuing on, open to the floor, or both of you. The question would be, how common is it to have 2 mutations in a gene?
Happens. I don't know the statistics, but we do have multiple patients in our center who have more than one mutation. Okay. Sometimes they have more than one bleeding disorder at the same time. So.
Right. Yeah, I would agree with that. I think it's hard to put an actual number on this. At the noon session with Dr. Rosenfield, we were talking about, Ehlers-Danlos syndrome and platelet aggregation defects. We see a number of patients who have platelet aggregation defects and some mild von Willebrand's. And I think if you did a whole genome panel on everybody in this room, we would have a variety of different mutations. Many of those would not be phenotypically, not going to cause any disease necessarily, but I think having dual and triple mutations is probably more common than what we really realized before.
Awesome. This is, where'd it go? Here's another one for either one of you. Do you test cord blood after birth? Oops, the screen skipped. Do you test cord blood after birth to see if they have hemophilia? As one of your tests.
If it's a pre-planned delivery, we do. A lot of times, if we didn't know, and the bleeding happens after the child's delivered, so that train has already departed, so we cannot. But if it's a planned pregnancy or known pregnancy and we were involved in the care, typically we do test, specifically for boys or in some severe cases.
We have a lot of women's questions, so I'm going to continue riding that wave, but really this is for both of you as our experts. This question is, what is the first step a carrier mother would take if, as she ages, she notices more and more bleeding episodes in her own life?
Just call the HTC and come to be seen. Again, a lot of times that's the conversations I just have with moms when they bring their boys to be seen. I ask them if they have been tested, do they know their levels? Are they active patients? Have they experienced abnormal bleeding? And just ask them to come in to be seen separately. But really, depending, we should not forget insurance. So a lot of times it does warrant a conversation with a primary care physician or provider to ask for a referral. But I would just really, anytime you have a concern, especially in the situation of a known carrier status, just come in.
Any thoughts? Okay. A lot of the time, I know that hemophilia is dominant in the conversation. It's in the name, but we are really here to talk about all bleeding disorders. So the next question is von Willebrand's disease related. The question is, what can VWD patients do to advocate? Sorry, the screen jumps every time someone submits, which is good. So what can VWD patients do to advocate for treatment advances? Without advocacy, we are getting left behind. Any thoughts?
There's, I think, events like this, certainly the advocacy days that are put by the advocacy organization. So I know that our center participates in the Hemophilia Alliance Hill Days. I have gone last year, so we've met with our representatives in Washington or their staffers, and we talked about the importance of ongoing funding and research. Certainly, bugging the pharmaceutical reps, every time you have a chance, because certainly that's we only have 2-factor products for von Willebrand's disease at this point in time. So if you compare that to hemophilia products, that's, ages and decades lagging, so yeah.
Yeah, I would totally agree in terms of advocacy. I do think that a number of centers have changed their name of their center. We were all used to be hemophilia treatment centers, and now we're bleeding disorder centers. I don't know if the New England Hemophilia Association is considering changing their name.
Definitely not a question.
I should have put that in the QR code.
Yeah. Submit that. That is not a question for me, but perhaps if you stick around in the next section, there is a meet the board session coming up. I don't know where Nancy is, but anyway, let's put that one on ice for a few. But Yeah, so we'll leave that on ice. I don't know if there's anything else to say for your response.
That's good.
Okay. But I do know that New England Hemophilia Association is excitedly interested in making sure that everyone finds a home here and no one is left behind, and making sure that there is a sense of inclusion that everyone feels collectively, which is why we're a wicked strong family. So ride that wave and make sure that that's very, eloquently and articulately said for everything. We're going to go to Dr. Larsen. What are your thoughts on prophylactic treatment for a woman with frequent bleeding episodes and a moderate factor VIII level?
So prophylaxis in general for patients with a bleeding disorder historically has been reserved and focused on patients with severe disease. But certainly at our center, I think most centers, each patient needs to be viewed uniquely, and we certainly have patients with hemophilia, von Willebrand's that they have frequent bleeds, and we actually offer them sort of at least a short-term trial pilot of prophylaxis, and you kind of see how things go for a few months, and then you can make a shared decision with the patient and family, was that worth it or not. But we certainly have patients with less than severe disease that are getting some type of prophylaxis. And for some patients, it's clearly the right thing to do.
I would agree that, there's severity determined by numbers, but certainly there's phenotypical presentation. So, when you bleed, you bleed. Numbers are numbers. You treat a patient. So certainly the prophylaxis is the modality that's out there on the table in the right circumstance.
And just to follow up on that, in terms of the numbers, just a number, our center, like I think a lot of centers, have like siblings and with hemophilia that have less than severe disease. Maybe they have mild to moderate, between 5 and 10%, and both siblings have the exact same number. That is the same percent, factor VIII or factor IX, but one's a bleeder and one's not a bleeder. And we've seen that a number of times. And so obviously there's a lot of other factors going into play, and clearly you have to really focus on what's happening with the patient clinically rather than the number.
Yeah, I always think of the commercials when they say individual results may vary, and I think that's a really important phrase to remember, that in all of this, individual results may vary. Each of us is on our own journey in many different ways, but especially when it comes to your bleeding disorder, one thing might work for one person and it might not work for another. One person's experience might be A and another person's experience may be X. So there can be great variances in those things. Excellent, thank you both for that. Here's a good question. Is there a difference, I am struggling with words, in rate of hemophilia or VWD among different racial and ethnic groups?
The answer to that is yes, and I'm afraid I can't articulate that right at the moment.
Sure.
Dr. Rosenfield? Oh, okay.
Sure. The answer for Dr. Rosenfield was that there seems to be a higher incidence in VWD in people of color. No? Yes. Does vary.
It does vary. Right?
Here, actually, since I have microphone, will travel. Just going to do this.
So there was, the CDC did look at numbers within the hemophilia treatment centers, asking individuals to self-identify with regards to their racial or ethnic background, and it appeared that the numbers were pretty similar for hemophilia with regards to white, African American, Hispanic, which I actually found interesting because we tend to see more white. However, with von Willebrand's, it varies, and it does vary based upon different populations that you look at, and I don't know those numbers per se.
Excellent. Yes, Glenn. Factor 11 can also vary.
Ashkenazi Jews.
Yes.
Yeah. Okay.
That's probably the reason for why Europe has factor 11 concentrate.
Exactly.
They just
Right.
have high
Okay.
numbers, yeah.
An interesting piece.
That's right.
We have about 5 minutes and 15 seconds left in this session. So just being conscientious of time, if there are any other burning questions, throw them into the mix as I finish up here, taking a look at some of the good, great questions that are coming in. Another one is, if you could send one message out to teens with bleeding disorders transitioning to adulthood, what would that be?
I think it's important to embrace the disease but not be the victim of the disease. What we sometimes see when teenagers transition from the childhood into the young adulthood, they tend to sort of relax because the parents are no longer there to care and to remind of the medication administration. There's certainly some damage can be done during that period. So I think that's sort of clinical importance, or the clinical message that the disease doesn't go away as much as you would like for it to not to be there.
I think we would also encourage teens to talk to their primary team at comprehensive visits. And they can select, they may want to talk to their physician, their nurse practitioner, their nurse, their social worker, but to ask to have some one-on-one time. In general, when our patients reach around the age of 12 or 13 years old, we offer them all an opportunity to have kind of one-on-one time during their visit, rather than being with their parents and other family members. Awesome. Just to give them an opportunity to express how they're feeling.
Excellent. I do feel a little like Orville Redenbacher because we got some popcorn going up here. Lots of things are coming in. So I got a couple quick fast rounds over here that I'm gonna throw at you. First one is, this is kind of a big one. Probably should have asked it a little while ago, but we're gonna do it. Gene therapy kind of scares me. Why would anyone do it with only limited data? And what happens after year 10, 15, 20? Is it reversible?
So we feel exactly the same way you do, for starters. And I'm surprised that question didn't come in sooner, because that's clearly the burning topic. We would obviously encourage everyone to discuss this with their primary team. It does seem like the data is somewhat preliminary. Interestingly, what I did leave out of my timeline was in the 1998, I went to a national conference, the American Society of Hematology, where I went to an educational session. In 1998, they said within 5 years, there'll be well-established gene therapy for both hemophilia A and B. And the speaker actually also said he didn't know why factor companies were still producing products. They're going to go out of business. So clearly that did not pan out the way we thought it did at that time. So it's been slow. And we share some of the same concerns that were mentioned by the person who asked that question, but I think it's sort of risk-benefit ratio. The other thing that's, what we don't know is what is gene therapy exactly, but at this point in time in 2023, we know what it's not, and it's definitely not a cure. The data for both A and B looks like you maybe get up around 30%. The data for 9 is a little bit longer, and that's maybe durable for 5 years, but we don't know the 10-year data. But so it's not a cure. So if you're hanging around 30%, you're still going to have limited physical activity. And also, oh, by the way, if you have surgery, you're going to need factor product. So you basically, interestingly, similar to emicizumab, you're sort of being converted from severe disease to kind of mild disease, but you still need to be managed for your hemophilia. But we're interested to see what, time will tell as more people are. We're certainly not encouraging our patients to sign up. We're sitting back and asking people to have those conversations.
Awesome. We're getting Gillette close here with a whisker shave, so coming down on time. The question popped in for rare disorders. Is tissue pathway a promising option for either one of you?
I believe so. I
Okay.
think it should work for all bleeding disorders, yes.
Love it.
Yep.
This one for you. We talk about carrier status for women. Are we moving more toward a diagnosis of hemophilia for carriers who do bleed?
Yes. I think, in my documentation, I actually usually put both diagnoses. I put carrier and hemophilia. And, I counted mild based on the number, but I do put both. So.
All right. I'm loving it, just like McDonald's. Someone wrote in, just going to say this one, keep your mother's voice in your head so you don't do something stupid. So there you go for that one. Whoever sent that in, thank you. Maybe I'll do two more. What are we missing in bleeding disorders, care, advocacy, etc., that other chronic diseases do much better? It's a good question.
I think we are more of an example for other chronic, diseases management. I'm coming from, I have experience in primary care and other adult specialty care. Unfortunately, from the historical perspective, with crisis of AIDS and hepatitis C, there's enough funding for the HTCs to provide comprehensive care. I don't know if any other chronic condition receives the amount of specialized and unique care as bleeding disorders do. So I think when I came to HTC, my thought was, I wish just primary care was the model, where you come in and you have a social worker, you have a dietitian, you have a physical therapist, and we can get a lot of people off a lot of meds by following that model. So I think we are more of a showcase than not.
All right.
Agreed.
Last question. All right, so before I do the last question, I will say there are still several more up here, and so I know I did not get to everyone's. I tried to group some of them together. Again, if you still have an additional question that you'd like to ask them, as they said, they'll be available. They can check in. Realizing that we're a couple minutes over, I'm going to ride that wave. Last question. How do HTCs decide which patients and diagnoses see different providers during a comprehensive visit?
It's usually our pre-clinic discussion. We try to strive for some continuity of care too, and whoever's available in the clinic that day.
Okay.
Yeah, I would say everybody has the opportunity to see everybody.
Yeah.
Yep.
Awesome. Let's get a round of applause for these guys.